Hello, folks. This is your CPR presentation. We're going to take a few moments to talk about what CPR is and what it's all about. When you talk about CPR, you need to understand that about every year, about 400,000 people in the United States die of sudden death, or what we call sudden cardiac arrest. These deaths often can be prevented with identification of risk factors and very quick access to CPR on the scene. It's been shown that cities like Seattle and Houston that have public health initiatives to teach CPR in schools and community centers have a much higher survival rate of cardiac arrest than do other cities. And when you talk about what cardiac arrest is, cardiac arrest just basically means the sudden stopping of the heart and breathing, resulting in unconsciousness and ultimately death. To contrast that with a heart attack occurs when one of the blood vessels that feeds oxygenated blood to the heart becomes blocked off, and that part of the heart becomes damaged. Now, the end result of a heart attack can be cardiac arrest, but cardiac arrest can happen for many other reasons, although heart disease is your most common reason. So it's kind of important to understand the risk factors of heart disease or heart attack, such as chest pain, shortness of breath, dizziness, nausea, pale skin, feeling of doom, and understand who's at risk for heart attacks. All right, as one of the most changeable risk factors we can talk about is cigarette smoking, very, very high risk factor. Uncontrolled high blood pressure called hypertension, diabetes, sedentary lifestyle, diet that's high in saturated fats are all risk factors for heart disease. So is advancing age, male gender, and family history as well. Contrast that, cardiac arrest is very common in people who have severe heart disease to begin with, but it can also happen in people without heart disease. The common denominator is that when sudden cardiac arrest happens, we only have minutes to act before irreversible permanent brain damage occurs. So if you see in this diagram here, when the heart stops, it doesn't really stop immediately. It loses its controlled function of the atria pumping and the ventricles pumping, and the first few minutes that heart tends to spasm and quiver, not pumping blood like it should be, resulting in unresponsiveness and pulselessness. We call that electrical pattern an arrhythmia. And so we're going to talk a little bit more about that in a while, but just for the sake of definitions, we have to define what certain age parameters are for the purpose of CPR. So for the purpose of CPR, an infant is considered from 0 to 1 year old. Child is considered from 1 to the onset of puberty. Onset of puberty being defined as the development of underarm hair in males, breast buds in females, and adult from puberty on. So if you have a child who's in between, you're not sure if you should do child CPR versus adult CPR, you really just make your best guess. I mean, there's a huge disparity of development between the years of these parameters, but it's just for basic guidelines. So there are very certain steps of applying CPR, and we're going to go through them all together. The first things first is to check for safety. Then you assess responsiveness. Send for help. Nobody can do it alone. Check for circulation and signs of life. Perform chest compressions. Open the airway. Give rescue breaths. And then repeat the cycles of compressions and breaths until advanced help is on the way and arrives. So the first thing you need to consider is don't go to any scene or any emergency unless knowing that the scene is safe. Your personal safety is paramount. You cannot help anybody if you become a victim, whether it's being chased by a flesh-eating shark or being chased around by angry Muppets. Your job is to keep yourself safe. But in all seriousness, think about things like traffic, wildlife, exposure to body fluids, if drug paraphernalia that you could cut yourself on. Think about all these things as well. It's also helpful if you have personal protective equipment with you, but that's not always possible. And we'll talk about some considerations for that. In the event that you are sure that the scene is safe, the next thing you want to do is check for responsiveness. Now, aside from what you may have seen on some certain TV shows, the best way to check for responsiveness in the adult and child is to simply tap on the shoulders and say, "Are you okay? Are you all right?" If you're talking about an unresponsive infant, you just want to tap on the bottom of the feet because they're very sensitive in that area. Don't shake the person, don't slap them in the face, don't pour cold water on their face, just tap the shoulders and say, "Are you all right? Are you okay?" Now, if the person or says, "Yeah, I'm okay," or makes any type of verbal response, then CPR is obviously not needed. So we're going to assume that when we're checking for responsiveness, there is no response. So we come on the scene, there's somebody on the floor, we determine there's unresponsiveness. Next thing we want to do is call for help. Now, in most instances, calling for help will entail calling 911. However, calling 911 is not always the most appropriate step. As we mentioned, first day of class, if you're on campus, it's a better idea to call on those red phones to let security know. Some communities don't have a dedicated 911 number. You still have to dial a 7-digit number to get emergency resources on the scene. Or maybe you don't have access to a phone. Maybe you need to point someone out of the crowd and have them call for help. It's always a better idea to point somebody directly in the face and say, "You, go get help. Call 911. Call a code," if you're in a healthcare setting. If you just say, "Somebody, please go get help," what happens? Everybody thinks everybody else went, nobody goes, and time ticks away. As I think I mentioned for class, once the heart stops beating, it only takes about 4 to 6 minutes for irreversible brain damage to occur. So the more time that's wasted getting professional help, the less chance of survival. So once you've sent somebody for help, assuming that most of you are going into the healthcare field, you're going to check for pulse and check for obvious signs of life. To check a pulse is simple. A pulse is a representation of the heartbeat. As the heart beats, it sends a wave of blood through all the arteries, and you can actually feel that wave of blood wherever an artery comes close to the surface of the body. One of the easiest places to check for a pulse is in the carotid area, the artery that travels up the neck. And it's very simple. You take 2 fingers and you slip them in between the groove of the Adam's apple and the muscle groove in the neck, and you take no more than 10 seconds to find that pulse. No more than 10 seconds. Technique is the same in the child. Remember, child is 1 to the onset of puberty. If you're referring to an infant, the guideline changes a little bit. It's very difficult to access a carotid pulse in an infant's chubby short neck. So what you do is you would take 2 fingers and palpate or feel for what's called the brachial pulse, the pulse that's in the middle of the upper arm. So carotid for adult, carotid for child, brachial for infant. That's a very common mistake that's made on the test, so please pay attention to that. To be the God's honest truth, pulse checks are very difficult. They're not easy. Even the most experienced healthcare provider can think they feel a pulse when they really don't. If the adrenaline's pumping and there's a lot of excitement, somebody checking for a pulse may actually feel their own pulse. So it's also a good idea to look for other signs of life. And we usually teach no pulse checks for layperson CPR and only check for breathing and signs of life. So what are the signs of life are we talking about? Are they breathing? Are they talking? Are they moving? Any of those. Obviously, when you check for responsiveness, as I said, and they say, what do you want? they must have a pulse. If they don't respond verbally but swat your hand away, they obviously have a pulse. If you can't feel a pulse but you obviously see their chest moving up and down, that's a sign of life. They have a pulse. But in the instance that you are not sure, you don't see any signs of life, and you're not sure if you feel a pulse within that 10 seconds, you're going to initiate CPR. To initiate it, and if the person starts going, ow, ow, get off my chest, then you know you've done your job. You're not going to make them any worse. So how does doing CPR compressions actually work? Well, it works in a number of different ways. Now remember, we said that all of a sudden the heart has stopped beating. The heart's job in itself is to pump blood throughout the body every hour, of every minute, every day of your life. It has a dual function. It pumps oxygenated blood to all the organs of the body so they can live. It pumps deoxygenated to the lungs so it can pick up new oxygen and recycle through the body. When that stops, brain cells start to die. There's usually a little bit of oxygen for the first few minutes still left in the blood. But if that oxygen does not travel to the brain cells, you're going to have permanent damage. So how do CPR compressions work? Well, by putting one or two hands in the adult, one to two hands in the chest, and physically compressing on the chest, you're physically squeezing the heart like a pump to force blood out of the chambers and into the bloodstream and all around to the body. The best performed CPR, however, only restores about 30% of normal circulation. It's also important to remember that just as important as pressing down is letting up. When you let up, you are allowing the heart to refill its chambers. If you're pressing too shallow or too quickly, that heart is not going to have enough time to fill up. And if nothing goes in, nothing's going to come out. The compressions are going to be suboptimal, less chance of this patient surviving. So to position yourself to perform chest compressions, what you'd like to do is preferably expose the chest. Put the heel of one hand right in the middle of the breastbone or the sternum, or we like to landmark right between the nipple line. You want to take your other hand and pull your fingers up. Lock out your elbows, lean forward so that you're almost making a 90-degree angle. So you're going to use your upper body weight to push straight down and let straight up. Straight down, straight up. If you're in the compression by the arms and bending your arms, you're going to get tired very quickly. It's best to lock them out and let your own body weight sink into the victim's chest. It's also important to know that you cannot do effective CPR if the victim is lying on a bed or a sofa or a soft surface. If you have the means, it's best to try to pull the person to a hard surface like the floor and do CPR on the floor. It's not always possible. You do the best with what you work with, what you have. If you're talking about compressions on a child, the proper technique is to use either one or two hands. There's really no absolute guideline. It really depends on the size of the child. If it's a really small child on the low end of the age spectrum, use one hand. If it's a bigger child, use two hands. If you feel very fatigued using just one hand, go back and use two. The technique is also a little bit different when you're talking about infants. It's actually quite a bit different. Instead of putting your hand on the chest, you're going to use the tip of two fingers. You're going to draw an imaginary line between the nipples, and you're going to go one finger's distance towards the feet, and you're going to compress the chest using that technique. So once you're finished giving compressions, you're going to go and assess the airway. You're going to open up the airway by doing what's called a head tilt chin lift. Most of the times when somebody's unconscious and their breathing is still working, the most common cause of that airway becoming blocked is that patient's own tongue falling in the back of the throat. So by lifting the chin up and pulling the head back, you actually lift the tongue off the back of the throat, and you're pushing and you're actually allowing air to pass through the airway. The technique is a little different with infants. The anatomy of an infant's airway is much different. Their heads are much bigger in proportion to their body, their tongues are much bigger in proportion to their mouths, and their trachea or the pipes are much smaller in diameter. So if you were to pull the infant's head all the way back like an adult, you would probably pinch off the airway like you were pinching off a straw. So for the infant, it's best to try to keep the head in the neutral position. Now, if you are unable to give breaths in the neutral position, pull the head back a little bit, but do not crank it all the way back like you would with an adult. And then you want to, one way, somehow give rescue breaths. Remember, this person is not pulling in air from the atmosphere to fill their lungs. By some means, we're going to need to push air into their lungs. Number of different ways we can do that. One of which is via mouth-to-mouth technique. I know that's an issue today with coronavirus, and it's always been an issue anyway, but it's still a valid technique. And how does mouth-to-mouth breathing work? Well, when you breathe in, the atmosphere, room air, contains about 21% oxygen, only 21%. The rest of the air is mostly nitrogen and water vapor and some inert gases. When you breathe that air into your lungs and your body only absorb about 5% of that oxygen. That rest of that oxygen, the 16%, is exhaled along with carbon dioxide in the rest of your breathing. So if by pinching the airway, pinching the nose, keeping the airway open, and making a seal with the rescuer's mouth over the victim's mouth, and physically blowing air into their lungs, you are giving them 16% oxygen in a situation where they only need 5%. So that's more than enough oxygen to keep them viable. Now, there are also other barrier devices to help prevent making face-to-face contact, one of which is something called a pocket mask. A pocket mask is a device you'll probably see that has an inflatable tube around the bottom, and it makes a tight seal around the victim's face. And it has a one-way inlet valve that allows you to breathe into the patient's airway and allows the air to divert away from the victim when the victim breathes out. Most difficult aspect of using this is maintaining a tight enough seal so the air doesn't leak out. It takes practice, it takes work. The pocket face mask or the face mask technique is the preferred technique of giving breaths when you are a single rescuer, when you do not have anybody to assist you. And by using the pocket mask, you're also, again, giving 16% oxygen. Another device that can be used is something called a bag valve mask resuscitator, or BVM for short. And I implore you to also look at all the demonstration videos that's in your Blackboard so you'll get a much better idea of what these devices are about. A bag valve mask device is a device that seals the face and delivers air via an inflatable rubber or plastic bladder. By pushing on that bag valve, you're infusing about 21% oxygen into the patient's mouth. And that BVM also be hooked up to supplemental oxygen, a little beyond the scope of this class, to deliver almost close to 100%. And this is the preferred technique if you have 2 or more rescuers or multiple rescuer CPR. And it comes in a number of shapes and sizes. Now, there's also something to be said for no breaths. So if you are on your own, you see the emergency, you notice that the person is down on the floor, you determine that they're pulseless and breathless, are you obligated to give mouth to mouth if you have no barrier device? Absolutely not. If you were to just give compressions until the ambulance arrives, you're still buying that victim a better chance of survival than if nothing were done at all. Remember what I said before, the body usually has about a good 3 or 4 minutes worth of oxygen in the bloodstream when the heart stops. However, if that oxygen in the bloodstream is not moved to the brain, it does absolutely no good. So even if you were to just do compressions, you're still getting more and more oxygen to that brain, and you're even pulling a little bit of oxygen in just by changing the diameter and the pressure of the chest. So it is perfectly acceptable to do compression-only CPR. When you teach CPR to communities and laypersons, they usually don't even teach the rescue breaths. But I know a lot of you guys are going to be going into advanced fields. So let's just go over CPR technique by age. So for the adult, and remember the adult is from signs of puberty on, you want to use 2 hands, center of the chest, lower half of the sternum, right between the nipples, and you want to compress, it says 1/3 of the depth of the chest, but you really want to go at least 2 to 2.5 inches. Child is age 1 to puberty. The technique is 1 to 2 hands, center of the chest, lower half of the breastbone, just like the adult, and you want to go 1/3 the depth of the chest and about 2 inches. Infant from birth to age 1, 2 fingers, center of the chest, 1 finger below the nipple line, and again, 1/3 the depth of the chest, about 1.5 to 2 inches indicated for the infant. And that's just stuff that you have to put to memory. So when you're doing compressions and lining them up with rescue breaths, you're going to do them in order. You're going to do, for the adult, when run rescuer, for every 30 compressions, you're going to stop and you're going to give 2 breaths, whether it be by mouth to mask, or BVM. You want to try to minimize the time that you stop doing compressions. When compressions stop, they become less effective, and it takes more compressions to become more effective. In the child, with the lone rescuer, the number of compressions to breaths is 30 to 2, as well as the infant. So anytime you have a single rescuer performing CPR, the compression to breath ratio is always 30 to 2, 30 to 2, 30 to 2. You will definitely see that on a test. When you have 2 or more rescuers, the numbers change a little bit. In the adult, you're still going to do 30 compressions to 2 breaths. 30 compressions to 2 breaths. In the child and infant, however, the ratio changes. Children and infant usually need more oxygen than adults do. In a children and infant, the ratio changes from 15 compressions to 2 breaths. 15 compressions to 2 breaths. So you're going to continue that until it's time to switch. Generally, you want to switch compressors after about 5 cycles in the adult of 30 to 2 or 10 cycles of 15 to 2. Should take about 2 minutes. It's very important to switch people compressing after 2 minutes, because it's been shown that after about 2 minutes, arms get tired, technique gets sloppy, efficiency of the compressions becomes poor, and the chances for better outcome decreases. So remember that. Switch after 2 minutes. And as we mentioned before, the physiology of CPR, the way chest compression works, is that positive pressure causes blood to be expelled out of the heart, creating what's called cardiac output. Some air gets pulled into the lungs, obviously not as efficiently as if you were giving positive pressure ventilation, but some will enter. And most importantly, intracranial pressure or blood flow to the brain increases, buying that person a few extra minutes, but the 4 to 6 minute timeline that we said will cause irreversible brain damage. So you want to perform CPR until a number of different circumstances. If the victim demonstrates obvious signs of life, starts coughing, moving, breathing, screaming, stop CPR. If someone of equal or higher training takes over, like EMS or a healthcare professional, or even another bystander trained in CPR and first aid, and you become tired, you can hand it off. In the healthcare setting, when an MD in charge, medical doctor in charge, directs so, some point it may or may not work anymore, and further efforts may be futile. In the EMS field, sometimes we call the medical control doctor at an alternate site, tell them, hey, we've been doing CPR for 20, 30 minutes, there's been no response. Give a little information about the patient, and we may get the order to terminate CPR on the scene rather than transport to the hospital. If you're presented with a DNR, DNR stands for do not resuscitate. Do not resuscitate. It's an example of something called an advance directive. An advance directive is a document of a person's medical wishes should they be unable to express those wishes at some point in time. A couple of examples of advance directives are DNRs, living wills, healthcare proxies. But a DNR for the purpose of CPR is the only thing that's recognized. It means person does not want compressions, does not want rescue breaths for a number of reasons. They may have a terminal illness. They may have reached that point in their lifetime where they're just ready to go. It's a personal thing for everybody. Obviously, if the scene becomes unsafe for whatever reason, it's acceptable to abandon CPR. It's not abandoning your patient. And if you are too physically exhausted to continue, well, then what can you do? If you're in a isolated, desolate location and somebody who's with you was in cardiac arrest, you can only do so much. Now, CPR with multiple rescuers usually involves, usually one person performs ventilation, one person performs compressions. Roles should be switched every 2 minutes. Pretty much what I just told you. If you're using an AED, which we will talk about later, the AED usually times and signals when it's time to switch roles. As I said before, if you're doing multiple rescuer CPR on the adult, it is 30 compressions to 2 breaths. 30 compressions to 2 breaths. And you can do that for 5 cycles and then switch roles. You want to try to do that with as minimal as possible. Because we're doing less compressions in the child and infant, we're going to increase the number of cycles. Instead of 5 cycles for the adult, we're doing 10 cycles for the infant and child. The math pretty much works out the same. Theoretically, if it's done with proper technique and proper pacing, both of those cycles should last about 2 minutes, give or take. And if you notice one more thing in this slide, when you're talking about one rescuer CPR for the infant, the technique to do compressions is with 2 fingers, bottom of the sternum, 1 finger below the nipple line. When you have 2 or more rescuers, the technique changes to something called the 2-hand encircling thumb technique. The 2-hand encircling thumb technique. So you see what they're doing. They've got both hands wrapped around the back of the baby, both thumbs on the bottom of the breastbone, and they're doing compressions with both thumbs about 1/3 the depth of the chest, usually making it a little more efficient. So going back to some basic numbers, remember that age in the adult is defined as puberty or older. Child is from 1 to the onset of puberty. Infant is birth to 1 year. Compression depth in the adult, at least 2 inches. In the child, it's 1/3 to 1/2 the depth of the chest, usually about 2 inches. In the infant, again, 1/3 to 1/2 the depth of the chest, 1.5 to 2 inches. The compression rate, how fast do you want to do those compressions? In the adult, at least 100 a minute, if not a little bit faster. Child is the same thing, at least 100 a minute, and the infant is the same thing. We're not going to really worry about newborn resuscitation. That's a little beyond the scope of this course. It's a little more complicated. Every time you give a rescue breath or ventilation, whether mouth-to-mouth, mouth-to-mask, or BVM, it should only last 1 second. How do you know that your breath is effective? Very simple. If you give a breath and you see just a little bit of chest rise, your breath has been perfect. You did the job. You expanded the chest. You got oxygen into that chest cavity. It's not like you're blowing up a balloon. It shouldn't take 5 to 10 seconds for each breath. It should be very, very brief. Where do you check a pulse in the adult? The carotid artery, right by the throat. Where do you check the pulse in the child? The carotid artery. Some people mistakenly say brachial for the child, but we only check the brachial pulse for the infant. One rescuer CPR compressions to breaths for all ages is 30 to 2. Multiple rescuer for child and infant is 15 to 2. Disregard newborn. We'll go back to this. What if you're alone? When would you call for help? Well, in the adult, after establishing unresponsiveness before beginning resuscitation. So you come upon a classroom or a hallway or someplace and you see adult on the floor. You're by yourself. You check for responsiveness. Hey, are you okay? Are you okay? There's no response. There's no obvious signs of life. In the adult, you want to go and call 911 or call help as soon as possible and then return and initiate care. The reason being is because most adults go into sudden cardiac arrest as a result of some upset rhythm in their heart, usually as a result of heart disease through the various risk factors. The definitive treatment for cardiac arrest is not CPR, it's the use of an AED, automated external defibrillator. That's the only thing that's really going to fix this. So the faster we get an AED on the scene, the better this person's chances of survival. In contrast to children and infants, most children and infants go into cardiac arrest because they've had some long-standing respiratory problem first. Asthma, pneumonia, RSV, bronchiolitis, things like that. So if you find an unwitnessed cardiac arrest in a child or infant, you want to assume that they've been without oxygen for a long period of time. And it's best to do 2 minutes of CPR and rescue breathing to get some oxygen into their system before making that call to 911. Very rarely do children go into cardiac arrest because of an intrinsic cardiac problem. It happens. It's rare. If you have a child and all of a sudden they pass out right in front of your eyes, looking otherwise healthy, that's probably what happened. Their heart went into arrhythmia, in which case it would be appropriate to go call 911 and come back. But for an unwitnessed cardiac arrest in a child or infant, you want to do 2 minutes of CPR, then make the call. An unwitnessed cardiac arrest in the adult, go make the call, then come back and do CPR. And again, in a perfect world, we'd have somebody that we could send for help, but this is assuming that we are alone by ourselves. Okay, and this is stuff that we already talked about. No, actually we didn't. There may be times when the victim has a pulse, has good cardiac output, and you're sure about it. You're definitely sure you feel that pulse, but they're not breathing, or they're not breathing adequately, maybe from stroke, maybe from a head injury, maybe from an overdose. And there may be a situation where CPR compressions are not needed, but rescue breathing is. In other words, you want to take over that breathing for them so they don't go into arrest. Well, we already know the age parameters already. We already know that in each situation, a rescue breath should take no more than 1 second. But how many breaths per minute are you going to give the adult? 10 to 12 breaths per minute, which would equate to about 1 breath every 5 to 6 seconds. 1 breath every 5 to 6 seconds will give you about 10 to 12 breaths per minute. Remember, children and infants need more oxygen than adults. So in the child and infant, it increases. You're going to give 12 to 20 breaths per minute. 12 to 20. In other words, 1 breath every 3 to 5 seconds. So in the adult, what you would do is you would give a breath, and then you would count 1 1,000, 2 1,000, 3 1,000, 4 1,000, and on 5 or 6, give a breath. In the child or infant, you would give a breath, 1,000, 2, 1,000, 3, 1,000, give another breath, and then you would take it from there. And then you would reevaluate, looking for signs of life, pulse, and whatnot, after about 2 minutes. So what happens when you have somebody who is choking? Okay, you're in a restaurant, they're talking, all of a sudden they stop talking, they have a panicked look on their face. You may see the universal choking sign as you see on all those signs in restaurants. First thing you do is say, "Are you choking?" If they're coughing and say, "Yeah, you moron, I'm choking, help me." If they're saying that, or if they're coughing forcefully, they are not choking. They may have what's called a partial airway obstruction. If that's the case, you want to leave them alone, encourage them to keep coughing up whatever it is bothering their throat. You do not want to slap them on the back. You do not want to intervene, because if you do that, you can cause a partial airway obstruction to settle down into a complete airway obstruction, and then your life is even more difficult. If they are showing signs of a complete airway obstruction, blue in the face, not making any sound, universal choking sign, you want to get behind them and do what's formally called the Heimlich maneuver. Make a fist with the thumb facing in towards the stomach, right above the belly button, the other hand over the fist, and you want to do abdominal thrusts. You want to squeeze in and up, in and up, in and up. By putting pressure on the abdominal cavity, you're forcing the diaphragm to squeeze the lungs and squeeze all the air out of the lungs, which is hopefully going to knock that obstruction out of the windpipe. And you're just going to keep doing it and doing it and doing it until one of two things happen. The foreign body is expelled and the person is breathing again, or until they become unconscious. Now, if this person is pregnant or very large or too obese for you to wrap your arms around the stomach, you can place your fist along the breastbone, the sternum, and do what's called chest thrust. Just about as effective. But again, you're just going to keep doing it and doing it and doing it until they clear their airway or until they become unconscious. If the victim becomes unconscious, believe it or not, things become a little bit easier. First thing to do is to assist them down to the floor, making sure their head doesn't go crash onto the floor as well. So you want to protect that head. Next thing you want to do is try to give CPR. You're going to start with 30 compressions at the sternum. The only difference is before you give a rescue breath, you're going to look inside the mouth, look inside the airway. If you see that piece of food or whatever they're choking on floating around, sweep it out. It's a good chance that when they became unconscious, the muscles in the throat relaxed and it let go of the foreign body. Now, if you don't see anything in that airway, you do not perform a blind sweep. You try to give a rescue breath. You try to give another one. If it goes in, great. You've cleared the airway. Then you reassess and check to see if it's a pulse. Could be that that foreign body went so far down the airway that it went down the trachea. If it was stuck in the trachea, no air is going to go in the lungs. But if it goes down far enough, it might have sunk into the right trachea, leaving the right bronchus, leaving the left bronchus open, in which case you have at least one lung clear for air passage. And one lung's better than none. At that point, they can fix that in the emergency room, but you bought that person a much needed amount of time to recover. However, if there's resistance to your breath, reposition the head, try again. If it's still not inflated chest, you're going to go right back to doing CPR compressions. Then check the airway. If you see, you sweep. If you don't, you don't. And then go back to rescue breathing. And that is the technique for both an adult and a child. Obviously, in a child, you're going to use a little less force. You may have to kneel down or squat down to position yourself appropriately. In the infant, the procedure is a little bit different. If you have an infant who's choking, who has a complete airway obstruction, what are you going to see? Well, infant's probably going to flail around their arms. They're going to probably look blue in the face, have a very panicked look on their face. Then it's pretty good to assume that they're choking. Because infants are small, you can let gravity assist you. The first thing you want to do is position the baby over your forearm with your thumb and fingers cupping the face, making sure you're not grabbing the throat, and angle the baby downwards on your leg, giving the baby 5 slaps right between the shoulder with the palm of your hand. We call that back blows. 1, 2, 3, 4, 5. Then, very carefully cradle the baby between your forearms and turn the baby over. And then give 5 chest thrusts with your 2 fingers, just like in CPR. 1, 2, 3, 4, 5. Pick up the baby. What is the baby doing? Is he still flailing around? Is he still got his eyes open? Is he still trying to make the effort to breathe? If so, you just repeat the process, repeat the process, repeat the process until you clear the airway or until the baby goes limp and unresponsive. The baby goes limp and unresponsive, same thing we talked about with the adult. You put the baby on a flat, hard surface. You do 30 compressions with the tips of your finger. You look in the airway, and if you see something, you gently sweep it out. If you don't see anything, you try to give 2 breaths. If you're doing mouth to mouth or mouth to mask, you would cover the mouth and the nose. Remember your head position. If the 2 breaths do not go in, you go right back to compressions. If the 2 breaths do go in, then you can reassess to see if there's a pulse and signs of life. So the American Heart Association gives a useful metaphor for what's called the chain of survival in the event of an out-of-hospital cardiac arrest. All the events that are needed to occur for a person to have the best chance of survival. The first is early recognition of the event and activation of the EMS system. The next link is immediate high-quality CPR. Okay, but CPR in itself is not going to fix the problem, usually. If it's a drowning or a smoke inhalation situation, it may, but in most cases of cardiac arrest, CPR is only a means to an end. The definitive treatment for out-of-hospital cardiac arrest is the use of rapid defibrillation through something called an AED, or an automated external defibrillator. An automated external defibrillator, which is well within the course of your training. Okay. Then the next 2 links are advanced care with the use of medications, IV lines, more advanced equipment, something the paramedics would do or what they would do in the emergency room, and then effective post-resuscitative care. But these 2 links here won't even be established if these 3 aren't put into motion. And you can do all 3 of these on your own. Okay, we'll skip over that. And that's where defibrillation comes in. Defibrillation is a treatment for immediate life-threatening arrhythmias. When we talked about arrhythmias, we said when the heart stops, it doesn't necessarily stop immediately. It still has some electrical activity within it that's not producing an effective heartbeat. So if there's still some electrical activity in it, there's something that we can work with. Now, this will not be on the test, but usually one of 2 things happens. The heart will go into something called ventricular tachycardia, where it will beat so fast but regular that the chambers just do not have a chance to fill up. And if nothing goes in, nothing goes out. Another situation would be something called ventricular fibrillation, or VFib, more common. This is when the heart just quivers and shakes and doesn't produce any type of efficient pumping mechanism. And the purpose of CPR, again, is to keep the blood circulating. So the more blood that circulates to the heart muscle itself, the longer this can be sustained, and the more you're going to save brain cells. keep doing CPR until we can get that AED on the scene. And as you can see here, when you have ventricular fibrillation and a shock has occurred, well, then you got boop, 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 a regular heart rhythm. CPR by itself will not do that. You need to deliver that shock. And it's pretty easy. If you look at the difference between hospital defibrillators and AEDs, AEDs are just as effective as hospital defibrillators. Hospital defibrillators, where they can monitor the complete rhythm, they can see it on a scope, they can calculate the precise dosage of electricity to be delivered. But the technology of defibrillation has become so advanced that you have automatic defibrillators, or sometimes what we call semi-automatic defibrillators, not only in hospitals, not only in healthcare clinics, not only on ambulances, but you also have them in restaurants, casinos, movie theaters. The technology is so easy, it's become user-friendly, that really anybody willing to give a helping hand can operate an AED. There was a study done some years ago assessing the effectiveness of technique in using an AED, and they compared sixth graders to seasoned paramedics, and they found that the sixth graders can operate an AED just as effectively as an experienced paramedic with all that training. Real kick in the ego of somebody like me. But what are the steps of defibrillation? Well, for one thing, confirm pulselessness. If CPR is already in progress, have them continue. Come on the scene, say, continue CPR, I have an AED. Place the AED close to the patient and the operator, wherever the operator is going to be. Very simple, turn the machine on. From that point on, most, if not all, of the AEDs will basically tell you what to do. There are many different models of AEDs out in the market. However, they all work on pretty much the same principle. Your job is going to be to apply the pads on the patient's chest. So the patient's chest is going to need to be exposed if it hasn't been already. And that has to be done while CPR is in progress. So again, the more we interrupt CPR, the less chances of survival. Plug in the pad wires to machine and allow the AED to analyze. So when you have the pads attached to the chest and you plug it into the machine is actually reading that electrical rhythm in the heart and deciding whether it's shockable or not. If a shock is indicated, the machine will advise you. It is your job to clear everybody from that patient. Make sure nobody is touching that patient, because if somebody's touching that patient when you deliver the shock, you're going to have two patients. So as it's charging up, which may take a few seconds, it'll give you the prompt to press the button and shock. Before you do that, at the top of your lungs, you want to yell, "Clear!" Then press the button. And once you press the button, you're probably going to notice the body tense up and jerk up real quickly. Every muscle in the body is going to contract. And then resume CPR immediately. Either you or somebody else. Either you start CPR or tell somebody else to start CPR immediately. But you're thinking, well, what if it worked? And what if it got the heart going again? Why would I want to do CPR? Shouldn't I check for a pulse? Technically, right. However, that heart has just been stunned and shocked. And it's going to take a little time for it to reset itself. Usually on the average, it's about 45 seconds. If you're wasting all that time trying to find a pulse during that, what we call reset time, the brain is not getting any oxygen. So it's much better to initiate CPR, the sooner the better. And if the patient starts showing signs of life, coughing, breathing, swatting away, you know to stop. And this really can't be reiterated enough, that the sooner the defibrillator arrives, the more likely the patient will survive cardiac arrest. It is the definitive treatment. So let's going over it again. Verify the absence of a spontaneous pulse. Check for no longer than 10 seconds. And that's something that a lot of people, especially healthcare providers, have a problem with. They doubt themselves, or they doubt that they can't find the pulse. If there's any shadow of a doubt, start CPR and start hooking them up. Very simple. Turn the machine on. apply the AED. Again, if you haven't done so already, you have to bare the victim's chest, male or female. Okay, if it's a female with a underwire bra, that has to come off because you don't want electricity being conducted through that metal inappropriately. Sometimes the patient will have a very, very hairy chest, in which case the pads won't make very good contact. Now you could do one of two things. You could use, most of these kits come with a razor kit where you can just quickly shave off the areas where you need to place the pads. That takes a little time, however. A lot of these sets come with an extra set of pads. You could do is put the first set of pads on the spots of the chest and then rip them off. You just better really make sure that patient is unresponsive first and put the second pair of pads on. Supervisors may not like that because pads usually cost a lot of money. If it's a pediatric patient, use pediatric pads or pediatric function on the defibrillator. Pediatric, child and infant do not necessarily need as much electricity as adults. So pediatric pads tend to attenuate or bump down the amount of current appropriate for the patient's size. However, if you do not have pediatric pads, it is appropriate to use the adult pads on a child or even an infant. Most important thing is to make sure the pads do not overlap or make contact. So sometimes what you might want to do is put one pad in the front, one pad in the back. So one provider should still, one or more providers should still be doing CPR while the other rescuer is setting up the AED. CPR should not be stopped because again, once CPR stops, the brain stops getting oxygen. And then once it starts up again, it takes more and more time to develop the pressure needed to what's called perfuse the brain or get enough oxygen to the brain to get it fed again. So minimal interruptions in CPR. Now, most AEDs, if not all, work on the same principle. They have universal pad sets that are designed to be placed in the same area. One pad will go right under the right collarbone. The second pad will go on the left side of the rib cage, where the heart would basically be sitting in between. And most sets will even diagram or label which one goes where. Do not panic. Even if you put them reversed, it will still work. It will still work. A lot of people don't believe that, but even if you mix them up, it will still work. All right. Now, again, as we mentioned before, if there's a small child and you have large pads, it's usually indicated to put one pad on the front, one pad on the back. If advised by the AED, press the button to deliver a shock, but only after you've yelled clear. So as that machine is charging up, you want to look up and down the victim's body, make sure I'm clear, you're clear, everybody's clear, and then once you're sure everybody is not or nobody is touching the patient, really loud, clear! Press that button. Immediately begin CPR after delivering a shock. Reassess patient after providing 2 minutes or 5 cycles of CPR. Usually, the machine will tell you after 2 minutes, stop CPR. It will reevaluate the heart's rhythm. One of three things will happen. If it's a shockable rhythm, it's not going to shock up. It's not going to charge up. And it'll advise you to either reassess the pulse or reassess the patient. If it goes back to a normal sinus rhythm, like you saw in that little picture, it'll say no shock indicated, reassess the patient. If the patient is completely unresponsive, still continue CPR, or that heart may have gone into a non-shockable rhythm, either flatline or something else, in which case defibrillation won't work. But unless there's obvious signs of life after the defibrillation, or after the evaluation, I should say, start CPR. Okay, perform CPR for 2 minutes unless the patient wakes up and starts to breathe. Okay, pretty much what I said there. And just to reiterate, when providing CPR, the rate should be at least 100 per minute. Very important to rotate personnel to prevent fatigue and prevent inadequate chest compressions. All contact with the patient must be avoided during the rhythm analysis. Pulse checks should not occur during rhythm analysis. And really, at the level of the first aid provider, or even at the EMT level, only an initial pulse check is indicated. At that point, no matter what happens, it's appropriate to check a pulse further down the line, because pulse checks means no compressions. No compressions means no oxygen to the brain. One rescuer operates the defibrillator while another does CPR, and maybe a third uses the BVM. Remember to rotate through. You need to kind of work with and coordinate with the people that you're working with. Somebody's going to need to take the role of the team leader and kind of delegate who's going to do what, and then call the shots when a change needs to be made. That's really, in a healthcare setting, that's usually the senior person. Out in the field, it's really whoever steps up to the plate first. But don't forget, CPR must include high-quality compressions. High-quality compressions. Substandard compressions will do that patient no good. And remember, defibrillation must come rapidly. And if you're working in a healthcare field, whether a volunteer or any other type of situation where you have an AED on the premises, take the time to become familiar with the model that you use. Again, they're all very user-friendly. Most of them come with instructions, and most of them prompt you on what to do, but it's still always better to be prepared. So let the operator of the AED complete the shock before you take over care of the patient. Otherwise, you may find yourself shocked. You may need to take the first AED to the, well, that doesn't really apply to you. Forget that slide. And some other things to consider when using an AED. First of all, well, we talked about what happens if the individual has a really hairy chest. All right, it's not, if the pads don't make good contact, they won't work. An AICD stands for an automatic internal cardiac defibrillator. AICD. Many people will have a little mini defibrillator surgically implanted into their chest. Maybe they've either survived cardiac arrest in the past, or they have very severe heart disease where they're prone to going into cardiac arrest. The cardiologist has said that they need this device. An AICD is directly wired to the heart and is constantly monitoring the heart. And if it goes into one of those weird rhythms we talked about, it'll immediately charge up and shock the patient. The patient will feel it. They'll feel it. They'll jump out and blurt. They'll scream. It's like getting hit in the chest with a hammer. A couple of things to know about a patient with an AICD. If the AICD has discharged a number of times before putting an AED on the patient, it still does not preclude you from putting the AED on the patient. If you're doing CPR on a patient with an AICD and it discharges, it's not going to electrocute you. It uses much, much less electricity than an AED because that electricity doesn't have to barrel through the chest wall or the muscles and bones to get to the heart. It's already hooked up. If you're doing CPR on a wet surface, you're going to need to move that victim to a dry surface. So if somebody at a health club has passed out in the shower in the locker room, do not defibrillate them in the shower room. Pull them out, dry them off. They don't have to be completely dry, but you don't want them to be in a puddle. We talked about issues with the child. You want to use child functions. However, if you don't have a child switch on the AED or if you don't have child pads, it is appropriate and okay to use the adult pads. It is not okay to use the adult pads on the child because it won't work. It won't deliver enough electricity, and it's better off just doing continuous CPR. If a person is in cardiac arrest due to trauma or a severe injury, then the AED is not really indicated because it's not going to work. It's not because the heart has short-circuited, so to speak. It's because there's been extensive tissue damage and blood loss. And the only chance of what's called a traumatic arrest surviving is rapid transport to a trauma center with a trauma surgeon on standby. And if the machine malfunctions, it's usually due to user error rather than a problem with the machine in itself. Most times it's appropriate to do a quick check on the machine before the beginning of the tour, before the beginning of your shift. You may not have that luxury if you're responding to an emergency on your own time. If the machine's not functioning, it probably means that the wires are not hooked up correctly, they're not making contact with the patient, or they're not plugged in, or it hasn't been turned on. Okay. Let's say that patient does regain consciousness after you've defibrillated them. Well, that's great. Keep the defibrillator pads on, keep it running, because if they've resuscitated, there's a very good chance that they may go back into cardiac arrest. So just keep that in mind. If you shock the patient and the patient has no pulse, and the AED is giving you a no shock indicated message after 2 minutes of CPR, you will just continue CPR. And if you notice that there are signs of spontaneous movement, there is spontaneous breathing, then make sure that you're still maintaining the airway and the ventilation. This person is only gasping for breath every once in a while, taking it like, that's something we call agonal breathing. That is not enough to sustain life. You may still have to do rescue breathing at 1 breath every 5 to 6 seconds in the adult, every 3 to 5 seconds in the child or infant. Okay. These last 2 slides are single rescuer with an AED. So if you're the single rescuer and you have an AED, remember, apply the AED and defibrillate immediately. CPR is only a bridge to an end. Once the shock is delivered or no shock indicated, then you begin chest compressions and 1 rescuer CPR until you receive help. So we already talked about contraindications. Do not defibrillate a soaking wet patient. Verbally and visually clear the patient before defibrillating. Do not defibrillate if the patient is touching anything metallic. Well, really, if you're on a metallic surface, like the back of a truck or anything like that, you really got to get them off of that surface before applying the AED. This is an example of what I talked about. The person is looking all around her, making sure her partner is not overzealously trying to help and touching the patient when she's about to give the shock. And this is an example of what I talked about an AICD being surgically implanted into the chest. So with that being said, if you have any questions, please feel free to post them on the discussion board. You have 2 weeks to complete this module. 1 week will be asynchronous, next week live. There are quizzes and tests. I implore you to look at all the videos that were posted on this section in Blackboard and review the study notes and the textbook PowerPoints to get a real better idea of what all this is about. And again, please, any questions about anything, whether it's on technique, whether it's on numbers, whether it's on circumstances, please post it on the discussion board and we'll be happy to discuss it. Thank you.